Hello, everyone. Just give me a few minutes whilst I set up my PowerPoint. I hope everyone's doing very well. Okay, can you all see my PowerPoint at the moment? Okay, good. So it looks like you can. So that's all working. Sorry, just my computer's being a bit slow, so just bear with me for a couple minutes. All right, welcome everyone. For those of you who don't know me, my name's Shoaib. I'm one of the co-founders of BiteMedicine, and it's an absolute pleasure to have you all here on a Saturday afternoon. I'm sure you could be doing a number of other things, but you've joined me today on our free live webinar on motor neuron disease. So this is part of a neurology topic that we're gonna start doing a lot more neuro, and that will mainly be led by me, and Azim will be doing some hepatobiliary stuff on jaundice and pancreatitis, etc. And I believe that's tomorrow. Last webinar we did Parkinson's disease, and I hope that was useful. And today, as I said, we will be covering motor neuron disease. So as usual, we'll be working straight through the pathophysiology right down to the management. But what I really want to tackle specifically today is the difference between upper motor neuron and lower motor neuron lesions, and how that's particularly relevant for your OSCEs as well. So there's going to be some high yield facts for both theory, SBAs, and OSCEs. And of course, we're going to cover all of the different types of motor neuron disease and exactly what you need to know for your exams, really. And hopefully this shouldn't take longer than an hour. I believe the slides have been uploaded to our website and the recording will also be up. But just before we start, a question to you guys. Why do you, so I know students struggle with a few areas, one of them being hematology, which we've covered, and the other one being neurology. So what is it that you find difficult about neurology? Because I understand it can be quite difficult, but I'd just like to, get your thoughts on it. Okay, so finding out where the lesion is, and there's just not good teaching on it. Okay, fine. Signs, how to classify things. So these are all really important points, and I completely agree. I agree. It is complex because there's lots of nerves and anatomy to know and physiology. So what I'd say is, much like hematology, once you have a classification system in your mind, a way of categorizing things, and just a simplistic way of thinking about things, then actually neuro is actually really interesting and fairly straightforward. Don't get too bogged down in the minute details because you'll get confused. So I'm going to teach you kind of everything you need to know and some broad principles. Someone has said, hi, thank you for these lectures and for doing them on the weekend. You are most welcome. It's our pleasure. Before we get started, so as you all know, along with the webinars on our website, we have a question bank, which consists of over 1,200 questions, taking a case-based approach, working right through from first steps, diagnosis, to management and pathology, as well as an online textbook, and that contains motor neuron disease. So please do check that out. There is a bunch of free content on there. So check out app.bitemedicine.com and you can have a look through these various things. But without further ado, have a look at that case. So we have a 69-year-old male presenting with increased clumsiness when he walks. Recently, he's tripped over twice and is unable to go jogging due to right leg weakness. On examination, he has bilateral leg weakness, which is worse on the right, and you note hyperreflexia and visualize fasciculations. So what do we think? Are we worried or not worried about this patient? Worried? So a couple of you saying worried. Yeah, I mean, obviously the lectures on motor neuron disease, and you know, if you ever have an elderly patient presenting with weird neurological signs, that's not good news. Obviously, we're not worried acutely that he's going to die in the immediate phase, but there's something odd going on here that that you need to investigate. So I would be concerned for sure. Okay, so let's go on to the next question, or the first question rather. Let's do these in Menti. So just think about that case. So it's a 69-year-old, and he's got some weakness, clumsiness, fasciculations, hyperreflexia. And if you go to menti.com, as usual, just pop in the code and you should be able to answer the question. I think someone said they don't have any audio, so I'm going to post the Zoom link. Hopefully that will help. So which part of the motor system is most affected, or most likely to be affected rather, in amyotrophic lateral sclerosis? Out of these: parietal cortex, dorsal horn, corticospinal tract, the muscle itself, or the neuromuscular junction? Okay, so we've got a split between the corticospinal tract and the dorsal horn, a few going for parietal cortex and neuromuscular junction. So what does the dorsal horn do? This goes back to our neuroanatomy. What is the dorsal horn responsible for? Sensory, sensation, good. Is the sensory system affected in motor neuron disease? No, because it's in the name. It's a motor. It's solely affecting the motor system. So that's how we know the dorsal horn is not affected. Parietal cortex is not involved in the motor system. That's a sensory, again, that's more sensory system. The motor cortex lies in the frontal lobe, okay? Let me just switch back to the PowerPoint. So parietal cortex is not part of the motor system. The dorsal horn is responsible for sensory system. The corticospinal tract, that we'll go into what that is, but that is the descending motor neurons from the motor cortex down the spinal cord. And these are definitely affected in motor neuron disease. The muscle and the neuromuscular junction are not affected in motor neuron disease. So can someone name a condition where the muscle is affected? So a neurological condition, or rather just, yeah, a condition where the muscles are affected. So yeah, Duchenne's, so myositis, so yeah, polymyositis or dermatomyositis. And what about the neuromuscular junction? Myopathy is good. So, but the neuromuscular junction, myasthenia gravis, and what's the other one? You need to know 2 for medical school. So not MS, yeah, Lambert-Eaton syndrome, good. So Lambert-Eaton syndrome and myasthenia gravis. That is the neuromuscular junction. So looking at this, what are the clues that this gentleman has motor neuron disease? What's the giveaway that this guy has motor neuron disease? Good. So someone said a mixture of upper motor neuron and lower motor neuron science. So let me go into that. Firstly, he's old. He's old and he's a man. So those are 2 risk factors for motor neuron disease. Clumsiness and leg weakness, those are fairly non-specific. They could mean anything, but obviously those are worrying symptoms. He's got bilateral leg weakness, which is worse on the right. So it's worse on one side, but it is bilateral. So hyperreflexia, for those of you who don't know, is an upper motor neuron sign, and fasciculations are a lower motor neuron sign. So hyperreflexia is upper motor neuron and fasciculations are lower motor neuron. And if you have no idea what I'm talking about, we will go into that. And just before I move on, give me a couple of differentials, because in your OSCEs, you want to give, say this is most likely in keeping with motor neuron, but I'd also like to rule out X, Y, Z. So what is the highest differential that you need to rule out in motor neuron disease? Okay, so we've got a few answers, which aren't bad. I understand what you're saying. It's MS, B12, but there's one specific thing that you really need to rule out. Yeah, so cervical myelopathy. Very good. Owen has nailed it. So it's called cervical spondylosis with myelopathy. Lots of long, confusing words. That's why neurology can be a bit annoying. But basically, all that means is spinal cord compression at the cervical level due to arthritis. Okay, so that's in layman's terms. That's what that means. And again, I'm going to go into this at the end of the webinar, so don't worry if you didn't catch it. But a lot of you said, things which are quite right: multiple sclerosis, stroke, not so much. We'll discuss that later, but not stroke. Classification of motor diseases. So muscular disorders, starting peripherally, the muscle, the neuromuscular junction, the lower motor neurons, the upper motor neurons, and then you have the extrapyramidal system, which, I mean, that's more controls the motor system. And we went over that last lesson, looking at Parkinson's disease. Today, we're going to focus on the upper and the lower motor neurons. And specifically, where the disease arises. What is a lower motor neuron? Where does that disease arise? What pathology does it cause, etc.? So, I mean, it's summarized here, but we'll go into it in more detail later. But what I really wanted to point out is motor neuron disease can cause both upper motor neuron and lower motor neuron disease. Okay, so that's the key take home from this slide. Other examples of upper motor neuron disease are MS and stroke, and other examples of lower motor neuron disease are your neuropathies and polio. And then we have a summary of the NMJ disorders and the muscular disorders. Someone's asked in the Q&A, can you reiterate which conditions are important to know for muscle problems? So that's on this slide here, and you should have a copy of the slides. So my question is, so this is an interesting question. A lot of you went for MS as a differential for motor neuron disease. how would you differentiate MS from motor neuron disease? It's a reasonable differential, I think, but how would you differentiate it? Good, it's only upper motor neuron. And what else do you get in MS? You get sensory signs, you get visual signs, you also get, what else do you get? Yes, sphincters, or you can get sphincter disturbance, but what else, what other system is affected in MS? At the back of the brain, controls coordination. So the cerebellum is also affected, and you get cerebellar symptoms, you can get sensory symptoms, you can get upper motor neuron signs. So there's a lot going on in MS, and the typical demographic in multiple sclerosis is a middle-aged female, not an elderly male. Obviously, elderly men can also have MS, but the typical exam demographic is a middle-aged female. Okay, so I always found the most pathways, or just like, you know, all the neuro anatomical pathways a bit confusing. So I want to just really simplify it. So let's say I want to move my right thumb, what's going to happen? The upper motor neuron in the left motor cortex is activated because the left motor cortex controls right-sided movement. So the upper motor neuron is anything in yellow on this diagram. It's anything before the synapse at the anterior horn, which is in green. Okay, so all of these yellow nerves are known as upper motor neurons. So if I want to move my right thumb, the left part of my motor cortex becomes activated, and that's up here in the precentral gyrus. I mean, that's not too important, but yeah, interesting fact. So it gets activated here, and then the signal comes down to the medulla where the fibers decussate. So they cross over here. The vast majority of the fibers decussate to form the lateral corticospinal tract, and a couple of the fibers do not decussate and they form the anterior corticospinal tract. The anterior corticospinal tract is not really important for you to know. This is the one we are concerned with, the lateral corticospinal tract, and that's the one that's going to make me move my right thumb. So just to summarize, if I want to move my right thumb, the left motor cortex is activated, you have upper motor neurons coming down, decussating at the medulla, in the pyramids, and then forming the lateral corticospinal tract. The upper motor neuron then continues until it reaches the correct spinal level for my thumb. So I can't think of what that might be. It's probably somewhere in the cervical or upper thoracic cord. And then it synapses at the anterior horn. Okay, and that's this green blob here. It synapses at the anterior horn, and then your lower motor neuron goes off to the thumb muscles. And then I can move my thumb. So the question is, what is an upper motor neuron and what is a lower motor neuron? So everything in yellow here is an upper motor neuron. The anterior horn, synapse, and the actual peripheral motor nerve, those are lower motor neurons. The reason that is so important to know is because a lot of you are saying it's really difficult to localize neurological lesions. But if you can recognize what an upper motor neuron lesion is from a lower motor neuron lesion, and that's really going to help you get your diagnosis. And actually in your OSCEs, when you're presenting back to the examiner, you shouldn't just jump to the diagnosis. You should say the patient has signs in keeping with both upper motor neuron and lower motor neuron signs. Therefore, my differential is motor neuron disease, but I'd also like to consider XYZ. So the point is, when you're presenting back to the examiner, you want to let them know that this is a mixed picture of upper motor neuron and lower motor neuron disease. I hope that will make sense, because that's probably the most important thing in this whole lecture. As we said, the upper motor neuron consists of the brain and the brain stem and the spinal cord upper motor neurons. The lower motor neuron consists of the synapse at the anterior horn and the actual axons leaving the anterior horn. So this green segment here, that is the lower motor neuron. Everything in yellow is the upper motor neuron. Good. I can see a question here. Do you mind explaining how to recognize fasciculations? I will come on to that. It's a good question. That's coming up. Right, next question. So now we know the pathophysiology behind upper motor neuron and lower motor neuron disease. I want to ask you, which of the following most suggests an upper motor neuron lesion? So we've got weakness, extensors weaker than flexors in the upper limb, hyporeflexia, lower limb weakness greater than upper limb weakness, or upper limb weakness greater than lower limb weakness. Let's see what you think. Good. So the extensors are weaker than the flexors in the upper limb. That's characteristic of an upper motor neuron lesion. In particular, a stroke, really. So that's more characteristic of a stroke, which is an upper motor neuron disease. But weakness you can get in both upper motor neuron and lower motor neuron lesions. Let's just go over to the answers. So yeah, weakness is seen in both upper motor neuron and lower motor neuron disease. Hyporeflexia, no, we expect hyperreflexia. Lower limb weakness is greater than upper limb or vice versa. So which limbs are affected just depends on where in the spine or the brain the lesion is. It doesn't matter if that's, you know, upper motor neuron or lower motor neuron. So the point is, particularly in stroke, the extensors are weaker than flexors in the upper limb. And I'm sure you may have seen stroke patients at some point, and their arms are flexed like this. So their bicep is flexed, their forearm, the bicep flexes their forearm, their wrist is flexed, and they hold their arm in a flexed position. Conversely, in the legs, in the lower limb, the extensors are stronger than the flexors, okay? So in the lower limb, their leg is extended, and that's why you have that classic hemiplegic gait or hemiplegic posture where the patient holds the arm flexed and the leg extended, and that's classic of an upper motor neuron lesion, and in particular a stroke. Good. So why do we have a difference in this pattern of disease? Why in upper motor neuron do we have, you know, hyperreflexia, etc., but in lower motor neuron lesions we have hyporeflexia? It's a bit complex, but all you need to really think about is those descending upper motor neurons, they regulate the lower motor neurons. So they control the pattern and the firing of those lower motor neurons. If you knock out the upper motor neuron, that leads to a particular pattern of disease, which is described here on the left. So as we described, the site is proximal to the anterior horn. If we think through our neurological examination, the first thing you do is you check tone. So patients have spasticity and or rigidity, and they have something called pronated drift. Okay, so that's particularly in a stroke. You get this thing called pronated drift. When you ask the patients to hold their palms to the ceiling, the affected side will start to pronate. Someone's asked, how do you check it? You just ask the patient, as on that picture, to put their palms facing the ceiling. On the affected side, which is this side here, it will start to pronate. And that's because the pronator muscles are stronger than your supinator muscles in your forearm. So when you have an upper motor neuron lesion, the pronators take over and they start to pronate your arm. So that's pronated drift. That's particularly seen in a stroke. What's the difference between spasticity and rigidity? So which one is velocity dependent? Good. Spasticity. So both spasticity and rigidity describe an increased tone. So when you're checking the tone, you're moving the patient's arm around. Their arm's going to be stiff in an upper motor neuron lesion. The difference between spasticity and rigidity is spasticity is velocity dependent. So the quicker you move the arm, the more stiff it becomes. But rigidity is just a constant stiffness regardless of the velocity. Okay, that's the difference. It's a bit technical, but you may be asked that. Power is reduced, and typically in the upper limb, extensors weaker than flexors, and the lower limb, flexors weaker than extensors. You have hyperreflexia, and you have no fasciculations. So if we compare that to a lower motor neuron lesion, the site is the anterior horn and distally. Tone is flaccid, so the patients have, when you start moving their arms around, for example, or their shoulders around, they'll have, it'll be really easy to move their joints and their limbs because they have very low tone. Power is also reduced, but it's not particularly reduced in this pattern that we described for the upper motor neuron lesion. The reflexes are either absent or they're hyporeflexic. So when you try and elicit their reflexes, it's really difficult, and you might not even be able to elicit their reflexes. And fasciculations are present. So going through some of these things, what is a fasciculation? Because that's quite important in motor neuron disease. How would you describe a fasciculation? Yeah, I mean, the easiest and the most sort of layman way to describe it is a muscle twitch. That's the way I'd probably describe it. It's a little twitch in the muscle. So someone asked, how would you assess for that in an OSCE? So you would look, if you're doing a lower limb examination, on inspection, before you even start your examination, spend 10 seconds just looking at the legs, and in particular the quadriceps, to look for any muscle twitches. Does anyone know how you can make those twitches come out? How you can make them more prominent? A technique that you can use in your OSCEs. Yeah, you flick or you can tap the leg or whatever muscle you're looking at. So you just get two fingers and you just tap the muscle, and then sometimes that can bring out a fasciculation. And where is the classic place to look for fasciculations in motor neuron disease? Obviously, you might be able to see them anywhere, but the sort of typical one that's described in textbooks, yeah, the tongue. Okay, so ask, even if you're doing a lower limb examination, on inspection, you can just ask the patient to open their mouth and stick their tongue out, and you can look for fasciculations on the tongue muscle itself. So that's the classic place for motor neuron disease. So if we move on, do motor neuron patients also have tongue wasting? Yes, they do, and we'll come on to that. So what is motor neuron disease? Okay, we now, in our mind, we kind of know the difference between a lower motor neuron and an upper motor neuron lesion. So that's really important. Now let's think about what motor neuron disease is. So it's a neurodegenerative condition, and you have degeneration of upper motor neuron and lower motor neurons. Okay, it's rare, and the incidence is roughly 2 per 100,000. So that means every year, for 100,000 people, 2 people will develop motor neuron disease. So it's a very rare disease, as you can see. It's a disease of elderly men. So 60 years old is the median age of onset, and males are more likely to develop it. Family history can be familial in 5 to 10% of cases, and smoking is thought to possibly be a risk factor. But the point is, we don't really understand the actual mechanisms and the pathophysiology and the etiology of this disease too well. Okay, next question. And whilst you're answering this question, I'll take one of the questions in the Q&A. So someone's asked, what's the difference between clasp knife and cogwheel rigidity? So cogwheel rigidity is when you have rigidity with a superimposed tremor, and you see that in Parkinson's disease. So I don't know if you can see my video, but what that looks like is when you move their hand, it's like very stiff and you have this jerky movement. That's known as cogwheeling, and that's Parkinson's. Clasp knife rigidity is when you're moving the hand, for example, and all of a sudden it just collapses like a clasp knife. And that's seen typically in stroke. So two different diseases. So is cogwheeling just PD or Parkinsonism? So yeah, Parkinsonism. Let's have a look at what you think. So SOD1 mutation, you might be thinking, what on earth are these things? Okay, so the correct answer is superoxide dismutase 1 mutation. That is the classical link. What is NAPK seen in? Where do we have NAPK excess? Stands for N-acetyl something, 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 which I can never remember. Seen in paracetamol overdose. Good. Amyloid plaques are seen in which disease? Alzheimer's. And PMP22 mutation, you need to know this for your OSCEs, because when you are saying what investigations you'd like to do for a particular disease, you'll list this and you'll look very smart. Yeah, Charcot-Marie-Tooth. So that's a really common, it's very rare in real life, but very common in OSCEs, Charcot-Marie-Tooth. So know this mutation. And know this mutation for motor neuron disease, superoxide dismutase 1. Because again, you'll look smart in your OSCEs if you say that. So SOD1, superoxide dismutase 1, is found in a small proportion of cases. Glutamate toxicity is actually thought to be involved. As we said, NAPK is seen in paracetamol overdose, and we discussed the other two. So amyloid plaques is Alzheimer's. PMP22 is Charcot-Marie-Tooth, also known as hereditary sensory motor neuropathy. So let's think about the pathophysiology in a bit more detail. So we have some genetic and environmental factors. You know, smoking might contribute. In terms of genes, we have this superoxide dismutase 1. Superoxide dismutase 1 is responsible for mopping up free radicals, okay? So if you don't have this protein or gene functioning correctly, you'll end up getting oxidative stress on the neurons, and that can lead to neuronal death. Other things which are going on that we need to think about: mitochondrial dysfunction. You can get misfolded protein, which can damage the motor neurons. Glutamate toxicity is thought to play a role. So too much glutamate causing motor neuron death. And you have a disruption of axonal transport. The point is, we don't really know the precise pathophysiology of this disease. These are kind of the key things which are going on. The one that you'll be tested on in your exam is most likely the mutation superoxide dismutase 1. But yeah, interesting to know. All of this stuff here, all the stuff in pink, leads to degeneration of upper motor neuron and lower motor neurons. And that is the final sort of end point in motor neuron disease, when you have degeneration of these motor neurons. So remember, the upper motor neurons are in yellow in this diagram. So that's all of these yellow, yellow upper motor neurons. And then down here in green, we have the lower motor neurons. Motor neuron disease results in degeneration of those, and that's what leads to your classic symptoms and signs. Okay, next question. Which of the following types of motor neuron disease has the worst prognosis? Amyotrophic lateral sclerosis, progressive muscular atrophy, primary lateral sclerosis, progressive bulbar palsy, or none of the above. So just looking at one of the Q&As, is motor neuron disease a type of Parkinson plus syndrome? No. So Parkinson plus syndrome produces a different type of symptoms and affects doesn't really affect the upper motor neuron or lower motor neurons. If you want to know about that in more detail, have a look at my webinar last week on Parkinson's disease. Good. Progressive bulbar palsy carries the worst prognosis of the motor neuron diseases. That's actually, for some reason, they like to test that in exams. It's rare, carries the worst prognosis. Amyotrophic lateral sclerosis is the most common. So progressive muscular atrophy, it depends what you read, but some people say this carries the best prognosis. But the point is, progressive bulbar palsy is particularly linked to a poor prognosis. Good. Next question. Which of the following would we not expect to see in motor neuron disease? Tongue fasciculations, muscle atrophy, ophthalmoplegia, hyperreflexia, or spasticity? So think about what we discussed, and hopefully you should be able to answer this question. Good. You don't typically get ophthalmoplegia in motor neuron disease. You can, but it's rare. For some reason, in motor neuron disease, the extraocular muscles are not affected. So tongue fasciculations, as we said, that's a typical finding. Muscle atrophy is seen. Hyperreflexia is an upper motor neuron sign, which we would expect to see. Spasticity, again, we'd expect to see. But ophthalmoplegia is not a typical finding in motor neuron disease. So let's go over the different types. The main one that we want to concern ourselves with is amyotrophic lateral sclerosis, also known as ALS. And if you remember a couple of years ago, there was a big challenge about like pouring ice on yourself to raise awareness about ALS. And that was referring to this particular disease here, amyotrophic lateral sclerosis. Predominantly affects the upper motor neurons. Well, actually, it can affect both the upper motor neurons and the lower motor neurons. So patients will present with mixed upper motor neuron and lower motor neuron signs. It typically starts unilaterally in one limb, and then over the course of the disease, it will spread to the other limbs. You can also get bulbar dysfunction, which I'll go into in a second, and it's the most common form of motor neuron disease. Okay, so motor neuron disease is very rare, but if the patient does have motor neuron disease, this is the most common form. Progressive muscular atrophy is a different form, and that affects the lower motor neurons only. So the way to remember that is muscles are a lower motor neuron, are affected by the lower motor neurons, and therefore only the lower motor neurons are affected. Primary lateral sclerosis is upper motor neuron only, and the way I remember that is lateral. Remember, the corticospinal tract is lateral, and the corticospinal tract is upper motor neuron. So primary lateral sclerosis only affects the upper motor neurons. Progressive bulbar palsy causes a predominantly affects bulbar function. So when we say bulbar palsy, we are referring to cranial nerves 9 to 12, and that really means speech and swallowing problems, and it carries the worst prognosis. You can get speech and swallowing problems in ALS, but if the patient predominantly has speech and swallowing problems, and that's the main primary thing of their illness, then that's progressive bulbar palsy, and that carries the worst prognosis. Good. So clinical features, as we said, these are general features, but progressive weakness of multiple limbs, falls, speech and swallow issues, particularly in progressive bulbar palsy, upper motor neuron and or lower motor neuron signs, depending on which type of motor neuron disease we're discussing. But if we're thinking about ALS, then it's both upper motor neuron and lower motor neuron signs. And as part of those lower motor neuron signs, you can get muscle atrophy, fasciculations, etc. Features we do not expect to see. You don't expect the sensory system to be involved. Extraocular muscles are usually spared. You don't get cerebellar signs, and the extrapyramidal system, you wouldn't expect extrapyramidal symptoms like you see in Parkinson's disease, like your bradykinesia, etc. So just to recap, motor neuron disease can affect either the upper motor neuron or the lower motor neuron, and you really need to know the difference for your OSCEs, because if you walk into a station and you elicit both upper motor neuron signs, so remember this patient had weakness, they had spasticity, or was it a hyperreflexia, and they had fasciculations. So they had a combination of upper motor neuron and lower motor neuron lesions. Then in that case, as I said, you'll present to your examiner, I elicited both upper motor neuron and lower motor neuron signs. The top of my differential would be motor neuron disease, such as amyotrophic lateral sclerosis, but I'd also like to consider other differentials such as XYZ. So that's the way you'd phrase it in your OSCE. Okay, let me just have a look at a couple of the questions. So how do you check for spasticity? So that's checking for tone. When you check for tone in your neurological examination, you basically move the joints around. So one of the things you can do is you can move the patient's shoulder up and down, you can move their elbow up and down, and if it feels stiff, then I would just say the patient has increased tone in your OSCE to keep it simple. And someone's asked, is proprioception considered a sensory symptom? Yes, proprioception is sensory. So looking at this picture, tell me what do you note? So imagine this is almost an OSCE scenario. What do you note in picture A? Yeah, so definitely I'd say there's muscle wasting of the upper limbs. If you look at the deltoid should be kind of round, and particularly as you go further down, it looks like there's muscle atrophy. He's weak because he has two people helping him stand up. So that's all about your inspection, okay? So this guy obviously has leg weakness. He can't stand up by himself. And if you look at the clavicle on the left, it's quite prominent. Again, that suggests muscle wasting. And it looks like you can almost see the head of his humerus there. So he's obviously got severe muscle wasting. What do you notice about his tongue? Yeah, it's wasted, it's atrophy, okay? I wouldn't say you can see fasciculations. I mean, you can't really see fasciculations on a picture because it's a dynamic thing. You need to see it in real life with a twitch. You can't see a twitch on a picture, but this irregularity of his tongue and thin tongue looks like it's a wasted tongue. Again, it looks like there's a muscle wasting at the back. You can really see his scapula really clearly. And if you look at his hands, the hands again look wasted, and in particular, the thenar eminence is very wasted. Again, look at his neck. You can see the bones very clearly and the tendons. That all suggests muscle wasting. So this is all part of your inspection in your neurological examination. And often in neuro, if you just inspect and ask the patient to walk, that will immediately give away the diagnosis. So those are key features. So motor neuron disease is typically a clinical diagnosis, but you do need to conduct other investigations to rule out other illnesses. So as I said, you need to do an MRI spine to rule out a spinal problem, such as cervical cord compression, or a demyelinating condition like multiple sclerosis. Respiratory function tests or pulmonary function tests, patients can develop respiratory failure in motor neuron disease. They lose their respiratory function and they may need respiratory support later on. So that's why pulmonary function tests are so important. The EMG may show evidence of muscle denervation. So the motor neurons denervating the muscles will produce characteristic findings, which I'll discuss later. And nerve conduction studies in motor neuron disease are typically normal. Okay. Let's move on to the next question. So someone's asked, with increased tone, does the patient find it difficult to move, or is it just when we move? So when you move it, you'll find it's really stiff. Okay, so which of the following management options prolong survival by the most? So you've got gastrostomy, riluzole, respiratory support, physiotherapy, speech and language therapy. So my question to you is, how long does riluzole prolong survival by in motor neuron disease? Do you have any guesses? Yeah, 2 to 3 months. That's pretty much right. Yeah, 2 to 4 months, roughly 3 months. How long does respiratory support prolong survival by in motor neuron disease? Months, about 7 months. So very good. Well done for knowing that. Okay, yeah. So basically, I was saying riluzole and respiratory support are both used in motor neuron disease, but respiratory support prolongs survival by a bit more. The other treatments are also used, but they're all supportive therapies. So riluzole prolongs survival by 2 to 4 months, and respiratory support by about 7 months or so. In your OSCEs, if you see a patient with, any chronic illness, whether that's motor neuron disease, Parkinson's disease, cystic fibrosis, whatever it might be, when you are explaining your management, you always say the management is going to be a multidisciplinary team approach. It's going to involve a neurologist, the GP, the physio, etc. And you list a few specialties, and then you go into specific treatments. So treatments prolonging survival are going to be riluzole, and that protects against glutamate-mediated neuronal toxicity. So remember when we going back to the pathophysiology, and that's why this is so important, one of the pathophysiology things that I mentioned that results in motor neuron degeneration is that you have glutamate toxicity. So for some reason in motor neuron disease, the glutamate neurotransmitter causes nerve degeneration, and riluzole protects against that. Nice, recommend it's used by a specialist, obviously, and it can prolong survival by, roughly 3 months or so. Respiratory support, so as we said, these patients, because they start to lose their respiratory function, the nerves supplying those respiratory muscles get affected, and they eventually need BiPAP at home. So that's a type of non-invasive ventilation. And that prolongs survival by 7 months. And then you can have a bunch of supportive therapies. So patients often get stiff muscles or muscle cramps, and you can use quinine or baclofen. They might need feeding support because they can't swallow. So you might put in a gastrostomy, also known as a PEG tube. And you may see this on examination in the OSCE. So the patient may have some sort of feeding tube into their stomach. They will need speech and language therapy to assist with their swallow and their speech, and physiotherapy to assist with muscle strength. I know there's a few questions, so let me get through the last couple of slides. We'll be done in the next 5 or 6 minutes, and then I'll come to your questions. So complications, as you can imagine, if the patient has a poor swallow, they're at risk of aspiration, they're at risk of respiratory failure, and as I said, swallow failure, so they're going to need feeding support. So it's quite a nasty illness, it's patients who are completely fit and well, and then a couple of years later, they're really deteriorating. And the prognosis after diagnosis, does anyone have any ideas what sort of rough prognosis is for patients with motor neuron disease? It's about, yeah, it's a couple of years, about 3 years or so. It depends what literature you read, but the point is, you know, it's a few years after diagnosis. You know, on average, these patients will start to deteriorate, die. And it's particularly about respiratory failure. They're unable to ventilate properly because they lose respiratory function. The differential diagnosis here for motor neuron disease, as I said, is cervical spondylosis. One of the other ones might be myasthenia gravis, or as you guys rightly mentioned, multiple sclerosis. You can think of kind of any differentials that sound reasonable. But the key one that you do need to mention is cervical spondylosis. So let's take motor neuron disease first. That's an upper motor neuron and a lower motor neuron problem. You have motor symptoms and signs only. It's a clinical diagnosis, and the EMG shows specific findings. In cervical spondylosis, that's where you have compression of the cervical spinal cord due to age-related spinal changes like osteoarthritis. You'll have sensory and motor symptoms. You'll have lower motor neuron signs at the level of compression where the anterior horn is affected. And below the level of compression, you'll have upper motor neuron signs. And you confirm it on MRI. Myasthenia gravis, that's where you will have muscle weakness, particularly proximally, and it's fatigable. So as the day goes on, patients become more and more weak. It's associated with acetylcholine receptor antibodies, and you can confirm it on serology and EMG. It also typically involves, it typically causes ptosis, okay? So myasthenia gravis typically causes ptosis. Which of the following, so just a revision now, just a few revision questions. Which of the following is characteristic of a lower motor neuron lesion? So hopefully this is something you guys can now answer. Which of the following is characteristic for lower motor neuron disease? I'll get to your questions in a couple of minutes. Just someone's asked, what's the other antibody that we test for in MG? So it's acetylcholine, the acetylcholine receptor antibody, and something called MuSK, muscle-specific kinase, which is seen in a small proportion of patients. Good, hypertonia. Weakness, of course, is also characteristic, but the point is weakness you get in upper motor neuron and lower motor neuron disease. So that's why hypertonia is the more correct answer. Next question, which of the following types of MND has the best prognosis? So amyotrophic lateral sclerosis, primary muscular atrophy, progressive bulbar palsy, progressive lateral sclerosis, or none of the above. So again, it depends on the literature, but some sources say primary muscular atrophy. The point is progressive bulbar palsy. I'm glad none of you went for this. That carries the poorest prognosis. So I won't go through the answers. That's there for you on the slides because these are just revision questions. But let's go to our top decile question. So if you just pop in your username and let's start. So which of the following may be seen in EMG in motor neuron disease? I have a feeling that I think this was mentioned in one of the slides. So, well, hopefully none of you saw it. Okay. Yeah, fibrillation potentials, good. I'll describe what that is in a second. But well done to Hermione Granger. Congratulations. You're very quick. So fibrillation potentials, these are things that you see on EMG and they suggest the muscle has been denervated, okay? They suggest denervation of the muscle. So an EMG is something that measures a muscle response, okay, to a stimulus. So it's measuring the response of the muscle to a stimulus. Fibrillation potentials are spontaneous potentials where the muscle fires, okay? The muscle contracts spontaneously. The reason you get that in motor neuron disease is because you have the motor neurons denervating the muscles, so they're not controlling the muscles as they normally do. And that leads to spontaneous contractions, which cause your fasciculations. And on EMG, you get a potential, which is called a fibrillation potential. So just to go over that, motor neuron disease, you have denervation of the muscles. The motor neurons normally control when the muscle fires, but if you lose that control, you have spontaneous contractions, which are known as fasciculations. And when you check the EMG, you'll see these potentials, and they are called fibrillation potentials. You shouldn't typically get slow conduction, and you usually have large amplitude EMG responses because, again, you're having these spontaneous contractions. You lose control over muscle firing, so you get larger amplitudes. EEG is looking at the brain electrical potentials, and hips arrhythmia is seen in a pediatric condition called infantile spasms, and that's something you need to know for your pediatric exams and rotations. So a recap, we know motor neuron disease consists of these 4 types, and it can involve both the upper and lower motor neuron disease. It's a clinical diagnosis, but you particularly want to do an MRI spine to rule out cervical spondylosis. And as we said, riluzole and respiratory support are the things that are going to prolong survival. I'll get to your questions now, so just give me a second. You please fill out the feedback form, so that's the QR code. Sorry. One second, my assistant's being a bit jammy, so I can't really see the Q&A at a second. You're very welcome. I'd be most appreciative if you could fill out the feedback forms, but let me get to your questions now. Here we go, the Q&A. You are very welcome. You're very welcome. Thank you for your kind words, and thank you for joining actually on a Saturday. I know it's not the best time, but sorry, I was just really busy at work this week. So I very much appreciate you all coming in. Okay, let's have a look. What's the difference between an EEG and an EMG? So an EEG looks at the brain, EMG looks at the skeletal muscles. Okay, so I think some of you got confused about cervical spondylosis and myelopathy, etc. So let me explain. So myelopathy, refers to spinal cord disease. That's all myelopathy means. It just means a problem with the spinal cord. Cervical spondylosis means a problem with the cervical spine due to some sort of bony age-related problem. So if you put those two together, cervical spondylosis with myelopathy, all that means is you have age-related changes in the spine, like arthritis, which then compress on the cervical spinal cord. So examples would be osteophytes, which compress on the spinal cord. Now, the next question some of you have is, why does that cause lower motor neuron signs at the level of compression and upper motor neuron signs below the level of compression? Because at the level of compression, the anterior horn, lower motor neuron signs. So that's why that's so important, why I discussed it earlier. At the level of compression, your anterior horn is knocked out, and that causes lower motor neuron signs at the level of compression. Oh, God, am I freezing again? Sorry. Okay, well, hopefully it kind of clears up, but okay, I'll go over that again. So at the level of compression, cervical cord compression, the anterior horn is going to be compressed. If the anterior horn is compressed, you're going to get lower motor neuron signs at the level of compression. Because remember, anterior horn is a lower motor neuron thing. If you compress a part of the spinal cord and you compress the lateral corticospinal tract, everything below that will exhibit upper motor neuron signs, okay? So everything below the level of compression is upper motor neuron because you're having those upper motor neuron corticospinal tracts being affected. But everything at the level of compression, because you're having the anterior horn compressed, you'll get lower motor neuron signs. So I hope that kind of makes sense. What else do we have? Can you explain why split hand sign could occur in motor neuron disease? Sorry, I don't know what split hand sign is, but it sounds interesting. What is suggested by the other answers, such as conduction block and slow motor conduction? So typically that suggests a neuropathy, so a peripheral neuropathy. Why upper motor neuron signs at the level of the lesion? So we've just described that. Some more questions about cervical spondylosis. How does BiPAP work? So, and how do you recognize it in an OSCE? So in an OSCE, it's basically this big machine with a massive like mask, and it'll be by the bedside. It's a type of non-invasive ventilation. It's a mask. The patient wears it over their mouth, and it has different pressures you can set it to, and it basically helps the patient breathe in and breathe out. So it kind of takes over some of the function of those respiratory muscles, which are affected in motor neuron disease. And that's why we use it. What specialty am I going into? So I'm currently a radiology trainee at Guy's and St. Thomas's. So for those of you at Guy's and St. Thomas's, feel free to come find me, and I would be happy to give you some teaching. Okay, I think we'll leave it there. It's just hit 1 o'clock. I don't want to keep you guys any longer. It's a Saturday afternoon. Go enjoy your day. Have fun. Any questions, you can post them in our Facebook group or email me. But again, thank you so much for coming, and see you tomorrow at our jaundice lecture, which Azim will be giving. So take care, everyone. It's been an absolute pleasure.